Everybody. So today, you have already gone through some of the topics: constipation, nausea, vomiting, and breathlessness. And we have an experienced faculty, um, Dr. Baburaj, who is the professor and head of the department of anesthesia at Government Medical College, Literature. He has been working in palliative care for more than 15 years. Um, and he has tried to integrate palliative care in various medical colleges wherever he has worked. Um, he he's a very good teacher as well as an academician. So I welcome Bhavdev sir to this session, and um, so I hope all of you will ask your doubts now. Anybody, please start.
Thank you, Sunil, for the introduction. Thank you.
Anybody? Have all of you gone through the topics, modules? Okay. So what are your doubts regarding the topic? This will go forward only if you ask doubt. So this is specifically for you to clarify your doubts, not for the faculty to take a session. You can ask whatever you want, even if it is there is not something called as wrong. So I like to ask you all a question on nausea and vomiting. What is your favorite antiemetic? Most of you might be practicing physicians. So, what is your favorite antiemetic? Yeah, I can see Dr. Anju says it's ondansetron. Anybody else? You can unmute and speak. Dr. Pankaj says it is perinom and insert. Dr. Nilakshi, metoclopramide. Riddhi says metoclopramide. So can any of you unmute and speak why this is your favorite antiemetic and why do you use it? Please speak. Nilakshi, Riddhi, Pankaj, Dr. Jayachandran, Jayanandan. Dr. Ishta?
Sir, it is according to which pathway the it is involved. If it is an chemotherapy-induced vomiting, I prefer on-time background, and if it is an opioid-induced vomiting, I prefer metoclopramide. Actually, in pathways, the main neurotransmitters involved are serotonin and dopamine. So mainly we use 5-HT3 antagonist and dopamine antagonist for
Okay. So, Dr. Ishta says the antiemetics should be chosen according to the pathway, which pathway is involved in um, signaling to vomiting center. So, Baburaj sir, I think you can talk about this a little bit.
Regarding the receptors? Regarding the
Yeah.
receptors?
Anything about the emetic pathway?
Probably the vomiting center, which is also known as a central pattern generator, it is actually coordinating the act of vomiting. Vomiting, is it active or passive process? Is it an active process or it is a passive process, vomiting? It is an active process, right? So, many things have to be coordinated. That means your abdominal muscles should contract. Actually, the stomach is literally squeezed between the downgoing diaphragm and the abdominal muscles. There should be reverse peristalsis. The glottis should close. The soft palatal should raise. Respiration stop. So many things, motor things have to be coordinated, and that center is known as the vomiting center, which actually receiving the various stimuli from centers like chemoreceptor trigger zone. Actually, it is in the floor of the fourth ventricle. And another source of stimulus would be the cortex, cerebral cortex. And it can also get impulses from the gastrointestinal tract. And the fourth would be the vestibular apparatus. So depending upon the site of origin of these impulses, the receptors also vary. So can anybody say the reason for this cortical vomiting? Cortical vomiting. Have you heard about cortical vomiting or anticipatory nausea and vomiting? It is also called anticipatory nausea and vomiting. It is very common in cancer patients. What is it? Anticipatory nausea and vomiting. Can anybody say?
Because of the patients on anxiety or previous experiences with the chemotherapy, if the patient is afraid that she will vomit, then it is known as anticipatory vomiting. And usually anxiolytics like lorazepam is given for that anticipatory kind of nausea and vomiting.
Yes. So usually that happens on the day before chemotherapy when they're planning for chemotherapy tomorrow, the evening onwards, or even the whole day they will be having the nausea. And the drug of choice, as you said, is lorazepam. Okay, and that nausea and vomiting is not responding to your serotonin antagonist or your perinome. What about the vestibular mediated nausea? What would be your drug of choice? Vestibular mediated nausea and vomiting.
antihistamines like
Yes, because there are. Yes, exactly. Because the receptors are mainly acetylcholine and histamine 1. So actually somebody said you need to know the pathway, right? So what's the advantage of knowing the pathway? Because you'll be able to know the receptors which are causing this or which are sending the impulses towards vomiting center. And if you know the receptors, you can select the antagonist to the receptors. And by giving the antagonist to the particular receptor, you can effectively prevent nausea and vomiting. Which is more distressing, nausea or vomiting? Which is more distressing?
Nausea.
Nausea. Okay. Vomiting means once you expels everything out, that the symptom stops, and nausea is actually continuous. Okay. What about morphine-induced vomiting? What would be the drug of choice? Morphine-induced vomiting. Morphine-induced vomiting, nausea and vomiting.
Metoclopramide.
Why? Why do you select metoclopramide? Why do you select?
Because it also acts as a prokinetic.
Yes. Actually, metoclopramide has got three actions. Right. Centrally, it is a dopamine 2 antagonist. So, the opioids, digoxin, uremia, so all these are going to stimulate the dopamine 2 receptors in the chemoreceptor trigger zone, CTZ, right? There is a major receptor in the CTZ. So, nausea vomiting caused by dopamine 2 stimulation, the drug would be a dopamine 2 antagonist. And the most potent dopamine 2 antagonist is haloperidol, right? As you said, metoclopramide has got dopamine 2 inhibition also, but the most potent one would be haloperidol. And the other two actions of metoclopramide are, one is it improves the gastric emptying, right? And the second peripheral action, you can say central and peripheral action. And the second peripheral action is, it increases the tone of the lower esophageal sphincter. So there are three actions. So of course you can give metoclopramide for morphine-induced vomiting, but the more ideal agent would be haloperidol. But practically we prescribe metoclopramide. Okay. So what are the things you elicit in the history? Somebody? So somebody comes with the nausea and vomiting, and in the history you need to elicit many things. Can anybody say? Would you like to ask about timing of symptom? When does it happen? Okay. Whether it is occurring after meals. Okay. Whether it is occurring on movement, it could be a vestibular cause. And somebody with a raised ICP, lying flat may cause nausea and vomiting because of the raised ICP. Okay, suppose it happens after a few hours after food intake, could be due to an intestinal obstruction also. So the timing of vomiting is very important because that give you a clue regarding the cause of vomiting. Now, gastric stasis, that is something which is very common in palliative care, right? Gastric stasis, that means delayed gastric emptying. Can somebody tell me the causes of gastric stasis? Why our patients in palliative care are having gastric stasis? Gastric stasis. And what would be the symptom and what would be the treatment for gastric stasis?
Bedridden for a long time. Patients are bedridden for a long time.
Inactivity. Okay, right.
Electrolyte imbalance.
Okay, of course, hypokalemia can go down to that. Diabetes, diabetes is a very common cause for, diabetic autonomic neuropathy. Then most of our drugs we use in palliative care can reduce the, starting from opioids, the anticholinergics, then the drugs used for neuropathic pain. So most of them will cause, slow movement. And what would be the symptom? There are certain symptoms which point towards the possibility of gastritis. Which are they? Fullness, right? They should be saying, I'm having a fullness of, belly, and there may be epigastric distress. Okay. Reflex, acid reflux esophagitis symptoms, hiccups, and very important one is early satiety. Now, what's the difference between early satiety and loss of appetite? Early satiety versus loss of appetite. So somebody may please speak.
In early satiety, when the patient has even a little amount of food, he feels full. He feels full.
Loss of appetite, there is no, there is no urge to take food. There is no hunger. But in early satiety, patient has hunger, but when he eats something, a small amount, has a feeling of fullness and that stops eating. So that is also a feature of gastric stasis. And usually in gastric stasis, the nausea may be very little. And the amount of volume, the volume vomitus will be large also. And once the patient, vomits, the symptoms are relieved. And how can you manage? We know the reason for gastric stasis, stomach is moving slowly due to multiple reasons. Okay. And we know the symptoms. And what would be the treatment? Somebody comes with symptoms of gastric stasis. What would be the ideal antiemetic?
Prokinetics can be given.
Yes, good. So can you name few prokinetics? One is metoclopramide, and the other one is?
Dom.
Yes, Domstal, domperidone. And what's the difference between domperidone and metoclopramide? Usually pediatricians are very fond of using Domstal. And many people are afraid to use metoclopramide, even in adult population, because of fear of extrapyramidal symptoms. But pediatricians are courageous enough to use Domstal. Oh, so what's the difference in mechanism between pyrinome and domperidone? So both are dopamine 2 antagonists, and metoclopramide acts on central dopamine 2 receptors, while Domstal or domperidone acts on peripheral dopamine 2 receptors. Okay, there's a major difference between these two. Now, if you are given an option of using a single antiemetic versus multiple antiemetic agents, what would be your choice? Single antiemetic agent or multiple antiemetic agents in a patient? Which one will you prefer? Single or multiple? Pardon?
Just start with a single one.
Yeah.
If the symptoms do not subside, then we can add another one from another class.
And a very important thing is in our patient, most of our patients, the etiology may be multifactorial. It is not because of a stimulation of dopamine 2 alone, ACH alone, H1 alone. So it could be a multifactorial one. So as you said rightly, you may start with single agent and judiciously you select the multiple antagonist. Okay. And you need to titrate the dose also because the dose for one person may be different from others. Sunil, would you like to add something regarding nausea and vomiting?
So mainly, what we have to understand is there are a few centers involved in nausea and vomiting. One is chemoreceptor triggosome and 5-HT3 and D2 receptors are predominant in CT set. Then we have vestibular apparatus, then cortex, then what else, Baburaj? Neurokinase.
Pardon?
What else? Which are the other centers?
Yeah, I think you have covered cortex, CT said vomiting center. Vomiting center. That is the central pattern.
All these centers, the signal will be coming to vomiting center, and vomiting center is known as the central pattern generator. So vomiting center will decide whether it needs to be a nausea or it needs to be a vomiting. Okay. So mostly the drugs and chemicals will stimulate chemoreceptor trigger zone, and usually the drug of choice would be a D2 receptor antagonist. And but in chemotherapy, it is usually 5-HT3 antagonist, and maybe all the cetrons, ondansetron, granisetron, palanosetron, all those are 5-HT3 antagonists. And yes, some people prefers haloperidol over metoclopramide for opioid-induced vomiting, but some people prefer metoclopramide. Both will have their own reasoning. Haloperidol is the strongest D2 blocker, which Baburaj sir already told you. But if you look at metoclopramide, it has, in addition to D2 blocker, in the CT side, it also has action on the GI tract. It is also a prokinetic. So some people prefer metoclopramide. So it depends on centers to centers, but there is a tendency to use 5-HT3 antagonists like ondansetron for opioid-induced nausea and vomiting, but that would come only in the last. So haloperidol, metoclopramide, then maybe other antipsychotics, and then maybe last ondansetron. But another important thing that everybody needs to understand is ondansetron has two side effects. Mainly, there are two side effects which we should aware of. Can anybody tell us what are those two side effects?
Constipation.
Yeah, and
I don't know.
yeah, sedation. Okay, but more than that, headache. But most important thing, most important thing is that everybody should know ondansetron would produce constipation, and we can see many patients come to us after chemotherapy on ondansetron with constipation, and there will not be any laxatives. So it is important that whenever you prescribe ondansetron or 5-HT3 antagonist, then you should prescribe a laxative also along with 5-HT3 antagonist. And from what Baburaj sir has described, you might have understood that we cannot blindly say this is my favorite antiemetic. The antiemetic should be selected according to which are the pathways involved, which center which center will be stimulated by the mechanism. All those have to be taken into consideration. Okay.
Okay. Now, one question to all: is there any problem in prescribing metoclopramide and buscopan together? Because anticholinergics are used if vomiting is due to intestinal obstruction. Okay, peritoneal meds, etc. Because intestine is having a lot of cholinergic receptors. Okay, so the vomiting mediated through these cholinergic receptors can be effectively blocked by anticholinergics, like we don't use atropine, buscopan, glycopyrrolate, etc. So my question is, can you use metoclopramide, which is a prokinetic, and an anticholinergic concurrently or together? Anybody? Or do you think you get a synergistic action? Because anticholinergic will act through the ACH receptors, and metoclopramide will act through dopamine 2 and also its prokinetic action. What is your opinion? Can you use it together? Or can you write a prescription? Tab metoclopramide 10 milligram Q6H or injection buscopan, like that. Anybody?
We can use simultaneously.
We can or we cannot?
We should not.
We should not. Why we should not?
Because both the actions are opposite type. One is just trying to stop, and another is trying to move.
Yes, exactly. Actually, for metoclopramide to act, it needs a cholinergic background activity. Then only metoclopramide can act. So when you give an anticholinergic, what happens is you are blocking it. So the prokinetic like metoclopramide and anticholinate should never be combined. It's a very important point because I have seen prescriptions writing injection buscopan and injection metoclopramide together. So perinom cannot act because there is no cholinergic activity. That is good. Good answer. Okay. And somebody can tell us the non-pharmacological measures. So we are describing the pharmacological measures of managing nausea and vomiting, and what are the non-pharmacological measures? Non-pharmacological measures.
Avoid triggering factors.
Yes, like
Strong
Maybe
sight, smell.
or
yes,
taste.
exactly. Cooking smell, especially the cooking smell, it can trigger. Then you can ask the patient about the unpleasant odors. You know, some patients they don't like the smell of certain foods, so you can ask. And then what about diet? What type of food do you like to prescribe? Small, different,
Small frequent meal.
frequent meals rather than the big chunks.
Bland.
Yeah. So that is a better management. That is a non-pharmacological measure. Now, I will ask you a few one-word answer questions. Okay. Anybody can answer. A drug of choice in opioid-induced vomiting.
Haloperidol.
Oh, metoclopramide. Okay, good. Drug of choice in chemotherapy.
Ondansetron.
Good. Serotonin agonist. Drug of choice in nausea due to renal failure. Because in renal failure and hepatic failure, the toxins are going to act on dopamine too. Of course, dopamine, metoclopramide or even haloperidol. Haloperidol will be more effective. Okay, metoclopramide you can say because of the dopamine 2 action. What about functional gastric stasis? What is the drug of choice? Gastric stasis. A prokinetic like metoclopramide. Okay, suppose it is raised ICP, the vomiting is due to raised ICP. What would be the drug of choice? As antiemetic. Yes, dexamethasone. Dexamethasone, good. And the patient says, I get nausea and vomiting whenever I move. Okay, movement-induced nausea and vomiting. What would be your drug of choice?
Antihistaminics.
Antihistaminics, right. And if it is interstitial obstruction, what is your drug of choice? Interstitial obstruction, malignant bowel obstruction. And vomiting is so common, nausea is so common. Obstruction can happen everywhere.
Metoclopramide.
Oh, if it's a partial one, partial interstitial obstruction, metoclopramide has a role along with steroids and, analgesics. And if it is a complete obstruction, metoclopramide can cause severe pain. Okay. In such a situation, you can think about a drying agent, which can dry out the interstitial contents, because the interstitial contents, which distance the abdomen and which, initiate a lot of, the sequelae like more secretions happening, bacterial colonization. So it is a vicious circle. So you can think about reducing the gastric secretion, and an ideal agent to reduce gastric secretion would be an anticholinergic, right? Or even octreotide. So actually, when you manage nausea and vomiting in this obstruction, you need to think whether it is a partial obstruction or a complete one. In partial, you can try metoclopramide, but in complete, don't give metoclopramide, you can give anticholinergics. Sunil, would you like to add?
No, that's fine.
I think we discussed.
I think we can move on to the next topic, breathlessness.
Breathlessness, okay. I think you can ask some questions to them. Breathlessness.
Anybody have doubts?
Any doubts regarding breathlessness?
How do you manage refractory breathlessness? Anybody? You might have seen patients with carcinoma of the lung, and you might have given bronchodilators and steroids. Still, patient is breathless. So, what do you do in such situations? Anybody? Okay, I can see Dr. Anju has written low dose opioids. Dr. Ratana says morphine. So, during your pharmacology, what have you seen written in textbook regarding breathlessness and opioids? What is the side effect of opioids, or what is the toxic effect of opioids?
Respiratory depression.
Sorry?
Respiratory depression.
Respiratory depression.
Depression, yeah. Dr. Pratana says the respiratory depression. So, how do you give morphine or opioids in patients with breathlessness?
You have to titrate the dosage.
Okay, what's the mechanism of action? Because in our pharmacology, we learned morphine is a powerful respiratory depressant. Okay. So somebody coming with breathlessness, the accessory muscles acting, patient saturation is around, let us say, 85 or 80. Patient is anxious, sweating. How can morphine relieve that symptom? What's the mechanism?
Anti-anxiety, sir.
Anti-anxiety. Okay.
Like in MI, we do give morphine.
Okay. Okay. It's a in MI, it's a good painkiller. It's a good analgesic. Okay. In MI, we give a morphine when somebody comes with LVF. What is the role in LVF?
Fluid distribution is
Okay, pulmonary circulation. There is a redistribution of blood from the pulmonary circulation to the periphery. Of course, that can help to relieve the lung congestion. Okay, that could be another mechanism. Anything else? Particularly, as Sunil says, asked, in refractory breathlessness. Any other mechanism? Somebody breathing at a rate of, let us say, 35, 40. In what way it is going to reduce it? And have you heard about hypercarbic ventilatory response? Hypercarbic ventilatory response. So that is one of the mechanisms of morphine, which release breathlessness. Hypercapnic ventilatory response, HCVR. Anybody? See, what happens normally is when there is reduced minute ventilation, okay, due to loss of lung tissue, as in case of malignancy or METs, or pleural effusion. So there is a restricted minute ventilation, reduced minute ventilation, right? So, and what happens when ventilation is reduced? What is going to happen to the carbon dioxide levels in the body? It is going to increase, right? Because ventilation, on purpose of ventilation is to expel carbon dioxide. So here is a patient who cannot maintain his or her main ventilation, and there is an increase in the arterial carbon dioxide, right? So what does carbon dioxide do to the respiratory center?
Stimulates.
Yes, carbon dioxide is the most powerful respiratory stimulant. Okay, it is going to stimulate the respiratory center, and respiratory center will be sending impulses towards the diaphragm and also intercostals, etc. And we'll ask, okay, breathe faster, because carbon dioxide building up, breathe faster. What do you think about the patient's ability to breathe faster? Is the patient able to breathe faster? No, because of the loss of lung parenchyma and effusion. So there is actually a mismatch. Carbon dioxide is stimulating brainstem and brainstem is sending impulses to breathe faster and the patient's respiratory mechanism is not able to cope up. So this mismatch between the central drive and the original ventilation. Okay. And this is called air hunger. This will lead on to air hunger. It's a gross mismatch. And what morphine does is it will reduce the air hunger by reducing HCVR. Because we know morphine will reduce the respiratory rate. Already I said somebody breathing at a rate of 35 or 40, morphine is going to reduce the respiratory rate. And the problem with tachypnea of a rate of 35 to 40 is that there is a lot of turbulence, isn't it? The airway, the air is moving in and out very fast, and this will lead to turbulence. And what happens when the turbulence happens? Suppose 100 people are going through a tunnel to and fro. What will happen? Lot of resistance, right? And when the resistance in the tracheobronchial tree increases, that will increase what? Work of breathing. Patient need to do more work of breathing. You can call this WOB. Okay, when you give morphine, it will reduce the respiratory rate, it will reduce the turbulence, it will reduce the resistance, and it will reduce the work of breathing. And we know dyspnea has got a breathless has got a subjective component. Studies.
Baburaj sir, your voice is-
Pardon? Am I audible?
I think you have.
Am I audible?
Yes, Baburaj sir, you're audible.
Yeah. Okay. So that is one of the action. Probably major action is it is reducing the air hunger by reducing the HCVR. And of course, somebody said anti-anxiety action. It will reduce the congestion, and it can actually has some effect on the mechanoreceptors. So multiple actions are there. Okay. And what would be the dose? Somebody said, I think somebody was mentioning about the dose of, so I heard low dose. What would be the dose, ideal dose? Suppose it is a ILD, interstitial lung disease, patient is having severe breathlessness. You have seen patient will be always trying to increase the oxygen flow in order to get relief. And high oxygen flow is not going to relieve his or her dyspnea. So where morphine will act. And what would be the dose of morphine? You give the same dose as in pain or less? Or would you like to titrate?
Lesser dose than for analgesic effect.
You need to titrate also. You need to titrate the dose. Okay. Sunil, would you like to say something more about morphine in breathlessness?
Baburaj sir has enlisted the mechanism of action, how morphine or other opioids relieves breathlessness. What is breathlessness? It's actually a sensation, isn't it? How do you get that sensation? Sensation is from the sensory cortex. So, morphine actually sedate the sensory cortex. So the feeling or the sensation of breathlessness is taken away. Okay. And in addition, Baburaj sir has also talked about other mechanisms. And you have to understand that for reducing anxiety, we have other good anti-anxiety medications. So for reducing anxiety only, we do not give morphine or other opioids. And yeah, so the dose of morphine, I can see Dr. Riddhi has raised hands. Riddhi?
Yes, sir. So I had a question. When if the patient is already on a high dose morphine for pain and also has breathlessness, so in that situation, how do we titrate the dose of morphine?
If the patient is already on morphine, you can increase the dose by 30 to 50%. So somebody is on 10 milligram. Okay. So you can increase to
Okay.
15 milligram like that. Always titrate because pain is an antidote to respiratory depressant effect of morphine, but breathlessness is not an antidote. So always keep this thing in mind. Somebody with
Yes.
pain will tolerate morphine, but breathless did not. So always try to titrate.
Okay. So instead of like increasing in for the pain, we increase by 50% also sometimes, but here we will increase by 30%.
30 to 50. They book
25
say
to 30.
30 50. What do you say, Sunil?
Okay.
It is 30 to 50, or you can say directly you can increase 50%.
You can increase 30 to 50%.
30 to 50%. Okay.
Okay.
But if the patient has only breathlessness, then somebody has told that the dose of morphine used would be less than that is used for pain. That's
Pain.
correct. There are various regimes for treating breathlessness. Even some people use 1 milligram per day, then gradually increase to 2 milligram, etc. But we usually use 2.5 milligram, maybe TID or 6 hourly with an SOS dose. And um, after seeing the response, then we can increase it. And usually only for breathlessness, the dose of morphine would be in the range of 20 to 40 milligram. So more than that for breathlessness alone is not usually needed. But if the patient has pain and breathlessness, then the dose will go up because you have to also treat the pain.
So when somebody is sitting in your OPD with breathlessness, you need to think about the causes actually, because multiple reasons are there for this breathlessness. What are they? Somebody can you can contribute the causes of breathlessness. Because in palliative care, we need to think about the correctables also, isn't it? Think about all the reasons. If correctable, you have to correct it, right? And then comes pharmacological measures and non-pharmacological measures. So never miss that correctable factor or factors. So you can contribute to the causes of breathlessness. Because only if you know the causes, you'll be able to manage. Pardon?
Pneumonia.
Okay, infection, right? Then?
Anemia, cardiac
Yes.
causes.
Okay, you can actually easy to remember pulmonary causes, cardiac causes. Okay, or like meds,
Hysterical, anemia.
effusion, but historical should be the last one.
That's
Okay, and major airway obstruction is a cause. Asphyxia obstruction is a major symptom. Lymphangitis carcinomatosis is a major symptom. Then pericardial effusion, that is also a cause. Then pneumonias, as somebody said, pneumonias. And treatment related, chemotherapy. How can chemotherapy lead to breathlessness?
Tracheal pneumonitis.
Then
Bleomycin causes.
yes, bleomycin. Then doxorubicin. Okay, and dreamycin can cause cardiac toxicity. Okay, radiation, even radiation just can cause pneumonitis and pericarditis. And always think about the associated medical issues. Patient could be an asthmatic, or patient can be a non-COPD, or patient may be suffering with ischemic heart disease. Okay, so never miss that point. So somebody having dyspnea due to ISD, diuretics have definite role. Congestive cardiac failure. So multiple reasons you need to think. Not only that, cachexia, simple cachexia can lead to breathlessness, and somebody said anemia. Steroid, long-term steroid can cause myopathy and can cause breathlessness. Hypokalemia can cause breathlessness. Huge ascites, hepatomegaly, all these can cause. So always keep in mind the possible reasons, and then you manage under the three subheadings like correctable, pharmacological measures, and non-pharmacological measures. Now, what are the non-drug treatment modalities for managing breathlessness? You don't use drug, but you may resort to something. Of course, you may be using drugs along with you have to do these non-pharmacological measures. Can you mention few measures. Then only your management is going to be complete. Anybody?
Using the fan.
Fan, okay. Fan, okay. Fan blowing air to face, good.
Well ventilated room.
Yes, when ventilated rooms, good. What about tight
Breathing into the
clothing?
bag.
Pardon?
Breathing into the bag.
Breathing in the bag, okay. How does it act? Breathing into the bag?
In that carbon dioxide
Actually, it
mechanism.
causes hypercarbia. It causes actually increases carbon dioxide. Sunil, what is your opinion about breathing into a bag? Actually, hypercarbia can cause sedation. What is your opinion? Breathing into bag?
I don't know.
Actually, I am not aware of this particular thing.
I don't know. I don't think.
Probably I think she's
Yeah,
trying
I
to
think,
mention about historical hyperventilation, right? In historical hyperventilation, we ask the patient, but it is not breathlessness. It is not
Okay.
breathlessness. Okay.
Okay.
And what about activity pacing? What do you mean by activity pacing? Somebody who is having breathlessness, would you like to confine him or her to the bed? What is the quality of life? Somebody is, confined to the bed. It is reduced, isn't it? So you can think about activity pacing. What does it mean? It is actually a lifestyle modification where you take rest between activities. For example, somebody is breathlessness and has to walk a few distance. Okay. So after, let us say, 1 meter, 2 meter, he can sit, take rest. Then again he can walk. So the important point is that before the person develops severe breathlessness, the person has to sit. That means you are promoting activity. At the same time, you are not allowing the patient to have, severe breathlessness, which is distressing. Taking rest between activity. For example, eat, take rest. Okay. Wash, you can take rest between activities. This is called a modifying lifestyle. And there are so many other things. You can actually, I said there is no need to confine them to the bed. They can help with the household work, kitchen. They can, cut the vegetables, sit to do tasks. Okay. So these are little things which will make them active. At the same time, you can manage them symptomatically also. Of course, along with drugs. And another question I would like to ask is, what's the meaning? This is one method. Encourage exertion to increase tolerance. What's the meaning? Encourage exertion to increase tolerance. What's the meaning? Actually, it is again a lifestyle modification. I said somebody who is able to walk up to, let us say, 1 meter, he or she takes rest, then walks 1 meter, takes rest. Now, suppose you feel that when a patient is symptomatically better, you can this 1 meter to 1.5 meter, right, or 2 meter. So gradually you are encouraging exertion so that patient is able to tolerate. Okay, so actually this activities, what is the advantage of making the patient active? Suppose somebody is bedridden, what will happen? All the muscles are going to atrophy, isn't it? So that is going to increase breathlessness. So you allow some amount of activity which actually should not cause too much breathlessness. That is called, activity pacing. I think that point is clear. Any doubts regarding that point? Activity pacing. Sunil, would you like to add regarding this non-pharmacological measures?
I think you have covered it well. And regarding the fan, the evidence is for a handheld fan. Okay. So by using a handheld fan, the wind towards your face, the mechanism of action might be it stimulates the trigeminal nerve area, which can reduce the breathlessness. That is supposed to be the breath mechanism of action. But otherwise, I think you have covered it, covered all the non-pharmacological management. And the breathing exercise is also important, which I think you need to teach the patient when they are not in severe breathless, when they are not severely breathless. Then if you teach them during the remission period, then they will be able to use this breathing technique when they have breathlessness. And I can see there is a question on pulmonary rehabilitation, and I think we are not actually the best people to describe about pulmonary rehabilitation, but that's a program mainly done by the physiotherapist along with the pulmonologist, where the patient is asked to there would need a lot of modifications in the lifestyle, a lot of breathing exercise, how to position the patient, and there are many things involved in pulmonary rehabilitation. So I don't know fully what all need to be done, but in brief, these are the things which is done.
Could be some posture drainage techniques or leaning forward. Somebody can lean forward. Earlier days we had cardiac tables, something called cardiac tables in ICU. Patient used to lean forward so that he can use his accessory muscles. Pectoralis major is a very good accessory muscle. So actually the combination would be the pulmonary rehabilitation. I think physiotherapy people will be able to say better about this one. And what's the role of oxygen therapy? Because it is a controversial subject, isn't it? Is oxygen therapy indicated in, let us say, somebody with ILD, right? Saturation is 75. ILD is irreversible thing. Would you like to advise oxygen for him? Anybody? Patient is conscious, not delirious or not drowsy. Patient is conscious, anxious, sweating. All the muscles are acting. What's the role of oxygen therapy? Anybody?
Oxygen therapy doesn't have much role. Only thing that trial with oxygen can be given to make the patient be comfortable and for reassurance that we are doing something sort of thing, and gradually it can be tapered off and taken out.
Exactly. Oxygen is useful if breathlessness is due to hypoxia. Somebody with ILD, it is not only the hypoxia causing breathlessness, it is a whole lung mechanism is lost. Okay. Suppose it is due to hypoxia, of course, that part can be corrected. So as you said rightly, you can try oxygen. It is called the oxygen trial. And the ideal equipment would be mask or prong. Mask, simple oxygen mask or prong for oxygen therapy. Prong, because mask is going to, obscure, it is actually something which can cause suffocation and, communication, feeding, everything is affected. So definitely you can go for prongs with a small flow. Always give small flow, because if you give large flow, 4 liters and above 4 liters, it can cause nasal crusting. And another thing is intermittent oxygen therapy is advised rather than giving patient 24 hours. You can give oxygen before and after activity. Okay, because an element of hypoxia which can happen after activity, so that element will be managed with the oxygen. And I think in thermal breathlessness, especially end of life, oxygen has no role. But be cautious whenever you start oxygen, because care patient as well caregiver should be fully aware of the fact, why are you stopping? Because the stopping oxygen can cause two things. One is patient may think, okay, I'm going to die. That is why they are removing oxygen. Okay. Second thing, if the patient dies, few minutes of within an hour or less, and the caregiver is going to attribute that duty. So always have a good discussion with the patient and caregiver. Okay, we can have a trial. We will see if it is improving breathlessness, we will continue. Otherwise, we will cut off. Cutting off oxygen doesn't mean that patient is going to die soon, because this oxygen, which is a drug, is not useful for this particular condition. Actually, a lot of explanations are needed when you start oxygen. Sunil, can you add more regarding oxygen therapy?
And before that, I would like to add that all the hypoxic patients are not breathless. All the hypoxic patients are not breathless.
Okay.
And even patients who have 100% oxygen saturation may be breathless. So this is what you have to keep in your mind. And so always, whenever we are in doubt, give a trial of oxygen. Maybe for 10 minutes, you have to give 2 liters of oxygen for 10 minutes and see whether the breathlessness improves. How do you assess whether the breathlessness is improving or not? How do you assess? Can anybody tell me?
Respiratory rate.
How do you assess? Respiratory rate?
Patient will tell that she or he is feeling better.
Yeah. So breathlessness is a feeling. It's our own feeling, isn't it? So you have to ask the patient, with this oxygen, how are you feeling now? Is it reduced or the same or is it increased? So you have to ask the patient. So that's how you have to assess. If the patient says, okay, I do not have any relief with this oxygen, then you can straight away discontinue. So before giving this oxygen trial, you have to actually discuss with the caregiver what are you doing, and the after effects means if after 10 minutes if this is not improving, then the oxygen therapy will not be good for the patient. So that's very important. And there is even in some patients, even with your opioids, that may not give a good relief for breathlessness. And in such cases, we would give something called as palliative sedation. And palliative sedation is sedating the patient and reducing his conscious level so that he would not feel the discomfort or distress due to that symptoms. So palliative sedation is only done in refractory symptoms when it is intolerable for the patient, and actually during when the patient is terminal. So palliative sedation is done given by sedative medications like midazolam, lorazepam, haloperidol, propofol, thiopentone. So all those medications or sedatives can be used to sedate the patient. But you have to be very thorough about when it needs to be given, what all needs to be documented, how needs to be titrated. All this has to be, you have to understand it properly. Then only you go for palliative sedation. Also, I just want you to introduce to the concept of palliative sedation. So this is done mainly when patient is having intolerable and uncontrollable symptoms during the terminal, when the patient is terminal. Okay. And I think now we can move on to constipation. Can somebody ask about or your doubts about constipation?
Is it a big problem, constipation? Is
Yes.
it a big problem?
Yes.
Why is it so?
Yes.
Why do you say so? You said it is a big problem.
Most of the
Because
time,
it
it's
may
not
lead to
diagnosed.
fecal
Sequelae, right?
Most of the time, it's
Because
not
they,
diagnosed.
Actually, it's undertreated and I think underreported also.
Yes.
Mostly because of social things.
Of delirium.
Okay, so especially in the elderly, it can cause delirium. Then most of our drugs can cause constipation, except few like metoclopramide. Most of our drugs are constipating drugs. Loss of, lack of activity, lack of food intake, lack of water content, water intake, lack of fiber content. So all this can lead on to constipation, and as somebody said it is a less reported symptom. Okay, what is your most favorite drug for treating constipation? What is your preference? Anybody? Bisacodyl. Why do you select bisacodyl?
Because it is a stimulant activity.
Okay. So in morphine-induced constipation, the choice would be bisacodyl. What about giving ispagula husk? Because most of our gastroenterology people are very fond of prescribing ispagula husk.
It is a bulk forming
Sir, as it
activity.
Yes, it's a bulk forming thing.
bulk
And,
forming, so it is contraindicated in constipation.
And what's the role in morphine-induced constipation? Ispagula husk. Is it indicated or is contraindicated?
It is contraindicated because it will cause there is soft bulk formation will already there is less motility.
Yes.
And the bulk formation may cause obstruction sort of thing and symptoms will be aggravated. So
Yes,
that's why it is not
yes,
indicated.
Yes, I guess two factors contributing to constipation are one is the water content, right, in the large intestine, in the stool, as well the intestinal motility, especially large intestine. So whenever the large intestinal motility is reduced, whenever the water content is reduced, that can lead on to constipation. So anything which points towards these two factors will cause constipation. And as you said rightly, bulk forming agents may not have any role in morphine induced. And would you like to add something along with stimulant laxative for morphine induced constipation? Anything else? Of course, by giving bisacodyl, you are going to stimulate the large intestine, right? Is it enough? Is just stimulation of large intestine is sufficient to, move forward these stools?
You can also use an osmotic laxative like
We can use to
it
lose.
can increase the water content.
So like, ondansetron, loose is also a favorite laxative for most of our doctors. I think in most of medical is also loose available, it is serum lactose. And as you said correctly, osmotic cathartic, it is osmotic. But here, of course, it will increase the bulk by, drawing water. The problem is long-term treatment with lactose can lead on to electrolyte imbalance. One. Second point, it is sugary. When you taste it, sugary. And third, it is costly. Can you think about any drug which can soften the stool? You can call it a stool softener. Because you want to move the stool. Pardon? Yes, liquid paraffin. Liquid paraffin. That's a train name. So you can think about actually a combination of stimulant laxative and stool softener is an ideal thing. And liquid paraffin. Somebody wrote liquid paraffin. And what about titration? Because you give morphine every 4 hourly, and you are increasing the dose also. And more constipation is the common side effect of morphine. Okay, because all the side effects patient will develop tolerance, like nausea, sedation, everything patient will develop tolerance except for constipation. So that is, it is said that a pen which writes morphine should also write a stimulant laxative, right? Of course, you have increased morphine from 10 to, let us say, 30 milligram. And patient comes to you telling that, okay, this bisacodyl 5 milligram, 2HS, liquid chromafene 20 ml, it's not useful. What are you going to do? That's the usual dosage, right? 5 milligram 2 HS, 20-30 ml HS, liquid chromafin. And patient says it is ineffective. I'm still constipated. Rule out impaction. Okay, somebody wrote rule out impaction.
Do PR examination.
Pardon?
Do per examination.
Okay, good. Correcting from rectal. Okay, that is something which is to be done with the consent of the patient. Okay. Then, so an important point is whenever you increase the opioids, these opioids are going to paralyze the intestine, right? So you can titrate up the dose of your laxatives. Sunil, your opinion? Increasing, because people are, they're worried about increasing the dosage. In medical college, when I tell my PGs about you increase to BD or TAD, they say, no, sir, it is only 2 HS dose. So your opinion regarding titration of laxatives?
So usually you can start a stimulant laxative like bisacodyl, 5 milligram 2 HS, that is 10 milligram, and it can increase up to 10 milligram TID usually. But there are some people who also tells that you can continue to increase the dose of bisacodyl till a good bowel movement gets. So anyway, you can increase it up to 30 milligram. So there is no dictum like okay, you need you can only give up to 10 milligram and stop it there. No, it's not like that. And another thing is that sometimes the stimulant laxative along with osmotic laxatives are used together, and if that's not working, then you may use PEG, that is PEG polyethylene glycol, which we use usually. It is used for colon washing during colonoscopy. So it is not the such a big amount of dose will not be used uh, in opioid-induced constipation. Even there are Peglex sachets are available. I think it is 18 grams. So maybe you can even Peglex powder can be taken, and 1 scoop can be used once daily and gradually titrate to see what would be the optimal dose. Okay, and in case of opioid-induced refractory constipation, then there is something called methyl naltrexone, which acts only in the GI tract to reverse the effect of opioids. But this is not available in India, but it is available in foreign countries like UK and USA.
Now, regarding cremafin, Sunil, cremafin versus lactulose.
Okay, so cremafin, it actually cremafin contains a lot of other things because liquid paraffin, milk of magnesia, and it also contains sodium picosulfate, something like that. But liquid paraffin, liquid paraffin is a lubricant laxative. That means it lubricates the fecal matter. But the osmotic laxatives, they absorb all of the water and they keep it along with the stool so that the bowel movement is induced. But usually, as Baburaj told, usually a stimulant laxative is combined with lubricant laxative like liquid paraffin. And if that is not effective, you try to titrate the dose, increase it, and see whether that responds. Then only you go for rectal interventions or other interventions like PEG-LAC or something like that. And lactulose Baburaj told that it has a few problems. The most important being the cost. And many people doesn't like the taste of the lactulose. So usually we do not use it, but some people use it.
And I think everyone should be aware of the very interesting symptom of spurious diarrhea. Can somebody tell about spurious diarrhea? Patient, comes to you who is already on morphine with a complaint that, okay, I was suffering from, I have been suffering from constipation since 2 weeks. Now, today morning onwards, there is some incontinence of stool. I feel I have developed diarrhea. This is the usual symptom. 2 to 3 weeks constipation and now incontinence, diarrhea-like presentation. How do you manage?
This is spurious diarrhea due to fecal impactation. So if there's digital evacuation and after that the clearance, the stimorphin will help later on. But
What's
you
the
have
reason?
to
What's the
take out
reason
the
for this diarrhea? Why diarrhea?
overflow. That is
What is
overflow.
overflow? Okay, what's the reason?
The
What's the
fecal
mechanism?
matter. Overflow of
What's the
fecal matter,
mechanism?
which is
What's the
mechanism.
mechanism?
It is already stool is softened. It is back. It is accumulated behind the impacted stool.
Yeah.
That is coming out.
Yes, actually, when the stool is, impacted and very hard, what happens is the upper part. That means the near that, colon, the bacteria will act and it will liquefy the stool, and the liquefied stool will seep down between the hard stool and the, large intestinal wall and going out. So for the patient, it is diarrhea developing after constipation. So whenever somebody comes with diarrhea, always elicit the history of constipation, because if you miss that history of constipation, you will be treating diarrhea. Actually, this patient is having severe constipation. And as you said, you can have digital evacuation, like you can put a catheter, carefully, because it can perforate the rectum and all that. And you can push in some glycerin or phosphate enema, and you need to continue laxatives for some more days, because usually these patients will be having stool not only in the rectum but also in the descending colon or even transverse colon. So you need to continue the laxative therapy for some more. A single digit evacuation and enema is not sufficient. You need to continue laxative some more days. Sunil, would you like to say something? I think it is 7:40. Any doubts regarding? I think as I saw one doubt, the role of fiber, right? Somebody, I saw a doubt. Role of fiber. Of course, fiber has a role, but in morphine-induced constipation, fiber will add on to bulk. So a stimulant laxative is the rule for morphine-induced constipation.
One question, sir.
Yeah.
Sir, I had one patient, 86-year-old female. She had lower rectal cancer, advanced locally, and she was having complaint of pain. With that, she was already having diarrhea, 5 to 6 times, small quantity, liquid, and 1 to 2 times only mucus or sticky secretions were coming out. So I started her on morphine, and she is better on the pain part, but I didn't give any laxative to her because she was already having diarrhea. So should I add anything, any laxative to her? Because after 2 days or 3 days of morphine, she is comfortable with the pain, but diarrhea is still there.
What is the diagnosis?
Advanced, locally advanced CA rectum with METs.
Okay.
So she never had any constipation, but because of the locally advanced disease, there was partially obstruction while passing stool earlier in the stage. But later on, she developed diarrhea, and it is still continuing.
So I think here the diarrhea is because of the local lesion invading the
Yes,
rectum,
sir.
right?
Yes, sir.
Yeah.
So with morphine, should I add any? Should we add any laxatives? Because I don't see any. As we discussed earlier, with morphine, we should try laxative.
Yeah. I think for this particular patient, no laxative is needed because patient is already having, diarrhea. What do you say, Sunil?
So, what I want to say here is, probably the patient has a reduced lumen due to locally advanced malignancy, and whenever the motion comes out, it doesn't come out as solid because there is only a small gap. It can come out only as um,
Liquid.
liquid. So, what I think here you would need laxatives along with steroid. I think if you put the patient on steroid, then some peritumor edema will be reduced and the bowel lumen can be increased. So if you do not give laxatives, then I think you have to titrate it carefully because uh, and there is partial obstruction. So that means if you give bisacodyl, it will increase the peristaltic movement and that can produce colic. So I think you should add a liquid paraffin along with bisacodyl. Bisacodyl maybe I would not start with 10 milligram. So Baburaj sir might be apprehensive about um, bisacodyl. So that's why he would not. He told that he would not have used bisacodyl. So maybe I would start with 5 milligram along with liquid paraffin.
Okay.
And a small dose of laxative, right? Small dose of, and again titration. Okay, keeping in mind the chance of colic due to the stimulation. As any role for enema suppository, Sunil? Bisacodyl suppository.
I'm not. I think I would do a rectal examination
Rectal
first,
examination. Okay.
and then we'll decide what is the status of the rectum,
Okay.
and then only I will decide.
Okay. So a tricky situation, right?
Yeah. We have a case presentation.
Okay.
So maybe we can do it.
Dr. Mohammed?
Ali, are you there?
I can see him logged in, sir, but he's muted. So.
Ali, please unmute. Priya, please unshare the presentation. I think we can continue to talk on any of the three subjects that we are planning to cover today. Anybody has any more doubts? Am I audible?
Yeah, you're audible.
Sir, at times we see that many patient who vomits, though it is bit out of the track, like in for chemotherapy also they come, they have incessant vomiting. Even they start after coming to the hospital, just being in the hospital, they start vomiting, and when the pre-med is also giving, that time also they vomit, and it is with ondansetron, pre-med, dexamethasone, and a supportive later on perinom also, it is very difficult to control. So one or two patient I tried low dose of ativan for them. Is there anything which will really work before chemo? Very few patient does that way.
The one thing is
Any
you can
other
increase the
regime,
dose
sir,
of.
which will control vomiting?
No, what is the dose of ondansetron? Ondansetron.
uh,
What's the dose? 8
8
milligram
mg,
or
sir.
4
8
milligram?
mg.
And how often? 8 hourly.
Yeah.
Okay, because serotonin stimulation is the cause of vomiting in chemotherapy. So you can just try increasing, or you can move on to other cetrons. That is one
So
method. And you can actually titrate other drugs also. And even
and I
Ativan is.
tried along with that metoclopramide also.
What is the impact?
Not much. Then finally I give Ativan, then we can start on the chemo. I don't know. I mean, in a very frustrated
Okay,
way, I
then
tried
stop.
twice.
Then stopped.
Yeah.
Okay, then
Sir, how
his
about
vomiting stopped after Ativan.
Pardon, sir?
His vomiting stopped after Ativan.
Yes, sir. Yes, sir. It happened.
So could be a anticipatory or even cortical nausea and vomiting.
Okay. So
Because,
anxiety induced or something.
yeah.
Okay.
So I already said multifactorial and
Yes, sir.
multi-pronged approach.
Yes. Okay, sir.
I'm an oncologist. I usually give NK1 receptor antagonist, aprepitant. I found it very good and effective.
Okay.
I believe in giving oral tablets rather than injections, so that they get it on the day 2 and day 3. I give as apricap, something apristar, something of that aprepitant. So there is some other thing is Nicron tablets are there, but it's so costly. Won't be able to give to many patients. It is also very effective. It is actually netopatent combination with palinosetron. The two advanced things that can be tried for chemotherapy in this movie.
Thank you.
Palinosetron, I think only single dose.
Yeah,
Per day, single
0.5
dose.
milligram. It's good. It's a second generation thing. I think it's better than ondansetron, although it's a little more costlier.
What is the price of aprepitant?
Around 2000, sir.
Yeah. So that's the problem. But if anybody can afford, then that would be good for them. But most of the patients may not be able to afford.
Now, another thing I think we can try is the PPIs. PPIs may have a role, gastric irritation, because patient is stressed. So PPI, you can try PPIs, proton pump inhibitors, if it is an incessant vomiting.
And there are some broad spectrum antiemetics. So we talked about haloperidol, which acts mostly on D2 receptors, and ondansetron or satron on 5-HT3, and antihistamines on H1 receptors, etc. But sometimes when you use these medications, the patient may not have good symptom control. So in such situation, you may use olanzapine, which is a broad spectrum antiemetic, which acts on multiple receptors. So maybe it will start with 2.5 milligram BD and see whether the patient responds. Some patients get good relief with olanzapine. And dexamethasone is, I think, you can say it's another broad spectrum antiemetic, and there are multiple mechanisms of action. So maybe even dexamethasone can be used in cases of severe refractory vomiting.
And there is one question in the chat box by Isha. Sir, can we choose metoclopramide as prokinetic in patient with brain mets? What did you prompt you to ask that question? Metoclopramide in brain mets? Any particular contraindication in brain mets? Isha?
Actually, sir, I want to ask whether it will cause extrapyramidal side effects. We are worried about the extrapyramidal side effects. So
But
if
all
we are
patients do not develop, right? All patients do not develop extrapyramidal, right?
Is it contraindicated in posterior post-vaginal?
No, I don't think. Sunil, is it contraindicated? Metoclopramide? I don't think in brain mets.
It's not contraindicated, but as you told, if there is any problem with the brain, then that might produce extrapyramidal symptoms. But we do use a lot of metoclopramide, and the extrapyramidal side effect is not a very common symptom, but it can happen, especially in patients who has HIV or patients with other problems. But you may use, but if you are aware, then you can use. That's what my goal says. If you don't know what all, you can use, because you know it can produce extrapyramidal factors. So you will be aware. But some other people may not be aware. So in such situation, they should not use.
So that means it can be used safely. Only thing is you can keep in mind the probable side effect, right? Okay.
And we use metoclopramide even up to 100 milligrams per day, sometimes in case of intestinal obstruction.
Okay. And this particular patient, I think dexamethasone is also having a role. Brain mets. It will reduce ICP by reducing the peritumoral edema. So you can combine metoclopramide. And if you want to make use of its prokinetic action, and if you're worried about EPS, I think Domstal would be another alternative. Domperidone.
Okay. Thank you.
And what's the treatment for EPS due to metoclopramide? Anybody?
Injection again.
Yes, promethazine. Injection promethazine.
So I think we can wind up the session for today. So we discussed about three important topics: constipation, nausea, vomiting, and breathlessness. So in breathlessness, you always think about whatever be the symptoms, you have to think in terms of whether there are any correctable things. So correct the correctable factors is the most important one. And then you have to give non-pharmacological management and Along with that, pharmacological management can be done. So in case of breathlessness, there are a lot of correctable factors. Then non-pharmacological management we have discussed, and there are some evidence for handheld fan and refractory breathlessness, or it can be treated with small doses of morphine. So thank you, everybody. Mr. Priya, it's over to you.
Thank you, Baburaj sir. Thank you so
Thank
much
you.
for
Thank you.
enlightening us on the topics. Thank you everyone for joining in and making the session interactive. With the promise that we'll be meeting again in the next session with more interactions. This is Sri Priya along with Dr. Baburaj and Dr. Sunil Kumar signing off from the Tipsy Cohort. See you in the next session. Till then, everyone take care, keep learning, keep spreading happiness. Bye-bye.
Thank you.